A foreign body airway obstruction, or FBAO, can occur at any moment. In the water, your only indicator will be feeling resistance or hearing noise as you blow into the Seal Easy mask. If an FBAO does occur in the water, your only option is to retilt the airway, readjust the mask, apply the jaw thrust, and attempt to breathe again.
The most important thing really is to be very deliberate while we're in the water. The most common problem that rescuers face is that they're not able to make a good seal or to get the proper tilt of the head in order to deliver the breaths adequately. So we really need to take our time and make sure our positioning and our effort is correct.
Once on deck, you have more options to address an obstruction. But remember, your first duty on land is to look for a pulse.
Well, once we make it to land, we really do have a lot more options as how we deal with that obstruction. But we always have to remember that the primary thing that we need to do once we get on land is to make sure that we do a pulse check, because we haven't done that to this point, and circulation is always our #1 concern.
An FBAO can become apparent if the rescuer feels resistance while squeezing the bag or blowing into the mask, or by the failure of the chest to visibly rise during ventilation.
Breathe! The chest does not rise and fall. Retilt, reseal.
When on land, your first step is to remove the mask, bring the head forward, and retilt the head back. Reseal the mask, making sure the hole is properly aligned over the mouth. Apply the jaw thrust with head tilt, and then reattempt ventilation.
Chest rise, chest fall. 1, 1,000, 2, 1.
If the chest visibly rises, continue rescue breathing.
When dealing with an obstructed airway or the potential for an obstructed airway, we first want to make sure that it is not our fault that by something that we've done or something that we haven't done that has been the cause of that obstruction. So we want to make sure that we're repositioning the mask, we're retilting the head, and have a good seal so that we can eliminate that as the cause of the obstruction moving forward, and then we'll know how to treat. If the ventilations go in on the second effort, then it was something that we had done. If they don't go in, then we can be comfortable that it is an actual obstruction.
2 minutes after artificial respiration is initiated, reassess circulation. This 2-minute time frame includes the breaths delivered both before and after the obstruction was detected, as well as the time spent clearing the obstruction.
It's necessary that we understand that 2 minutes, when we talk about a 2-minute reassessment, is 2 minutes, regardless of the care that's given in between. So if you spend some time on establishing an airway or you're actually delivering the AR ventilations, that doesn't matter. It's 2 minutes from the initiation that we have to reassess, because circulation really is our priority here.
If during that second attempt at ventilation you continue to feel resistance and the chest is not rising,
the chest did not rise.
One rescuer must immediately position themselves to perform chest compressions. Use the appropriate landmarks for an adult, child, or infant. Deliver 30 chest compressions, applying the required compression force relative to the size and age of the guest. After 30 compressions, perform a visual check of the mouth. If an obstruction is observed, remove the object. For adults, use a finger sweep. Do not use this technique on children or infants. And remember, never use a finger sweep unless the object can be seen. For children and infants, just pluck the obstructing object out of the mouth.
We really don't want to use a finger sweep on a child or an infant because their mouths are much smaller and they haven't quite fully developed yet. So we really want to avoid causing any further injury, and we're much better served removing an object by using a plucking method.
Once the obstructing object is removed, open the airway with the head tilt and jaw thrust. Seal the mask and attempt ventilation again. If the chest visibly rises, continue artificial respiration for the remainder of the 2 minutes. If the chest fails to visibly rise or resistance is still being felt during ventilation, repeat the obstructed airway and chest compression process over and over until the chest rises and falls.
So we've taken the effort to reposition our mask and our equipment and to do some chest compressions to check the mouth to see if there was a physical obstruction. If we haven't found a physical obstruction yet, meaning we're not able to get that chest to visibly rise on our next ventilation, then we're back to the beginning until we're able to get that air to go in and notice that chest rise and fall.
If a guest begins to vomit at any point during care, carefully roll the guest onto their side and into the recovery position. Finger sweep the excess fluids out of their mouth, or use a manual suction device to suck out any remaining fluid. Always follow the manufacturer's instructions while using a suction device. Once the vomit has stopped and the fluid has been cleared, roll the guest onto their back. Resume care where you left off.